Respiratory pharmacology. Common symptoms of respiratory disease is a cough. So it's a protective reflex which prevents the lungs from aspiration and expels secretions from the lungs. You can have a useless, unproductive dry cough in, for example, asthma or an esophageal reflux or sinusitis or psychogenic. And it should be suppressed. In this case, you'd use cough suppressants called antitussives. Or you could have a useful cough, which expels secretions, i.e. produces sputum, and this is called a productive cough. This you'd get in, for example, a chest infection, and this should not be suppressed. Unless if it's exhausting and dangerous. Cough receptors or lung irritant receptors then transfer a signal to the cough center in the medulla, and vagal stimulation then leads to a cough. A dry cough can be suppressed with antitussive cough suppressants, and in the afferent side you can reduce stimuli, and at the efferent side you can work on the medullary cough center, and that's where the antitussives come in. So, reducing stimuli, for example, you could do above the larynx using Linctoses, and below the larynx using steam inhalation or nebulized local anesthetics. And at the medullary cough center using antitussives, you can use opioids such as codeine, methadone, and fulcodeine, or non-opioids such as dextromethorphan and noscapine, or sedatives such as diphenhydramine or chlorpheniramine. If there's a productive cough, you can use expectorants. These increase the volume of the secretion. There's guaifenesin and ipecacuanha, and there is no added value to an expectorant, it's just an increased volume of secretion. Mucolytics decrease the viscosity, so acetylcysteine and recombinant human DNAs, these can be used for cystic fibrosis. So with chronic lung disease, there are different principles for appropriate treatment. There's different types. You can have inflammation, which causes mucosal swelling, bronchoconstriction, which affects the smooth muscle, and secretions, where you work on obstruction. So due to narrowing of the airways that conduct air into and out of the lungs, this can be caused by inflammation of the linings of the airways, particularly of the smaller airways, when the lining swells and causes blockage, and or mucus plugs obstructing the lumen of the airways, which occurs in acute or chronic infections when there is excessive mucus secretion, and or constriction of the smooth muscle in the walls of the airways, causing airway narrowing. Asthma is associated with allergic reactions, for example, type 1 hypersensitivity reaction, which would be with a specific allergen. So type 1 is specific allergen. Asthma, not associated with a specific allergen. You could have intrinsic asthma or no identifiable antigen, and exercise-induced asthma, and asthma associated with COPD. Prevention of AG-AB reaction, you would avoid the specific allergen, or non-specific reduction of bronchial hyperactivity, or there could be a non-pharmacological action such as stopping smoking or weight reduction, and pharmacological, you would be using corticosteroids. And dilation of the narrowed bronchi, you can mimic the dilator neurotransmitter, and these are sympathomimetics, or direct-acting bronchodilators such as methylxanthines. Blockade of constrictor transmitter would be with anticholinergics, and prevention of the release of transmitter with mast cell stabilizers. Antagonism of release transmitter would be with leukotriene receptor antagonists. So allergen-mediated asthma and the approach to treatment. So an antigen is getting in here through the protective area, and then the antigen will go on the edge of an antigen-presenting cell, and then this antigen presentation leads to IgE production, which leads to mast cell activation and release of mediators. And yeah, there are various ways you can try and stop that happening. The exact mechanism is not known, but corticosteroids' effect include inhibition of influx of inflammatory cells after exposure and inhibition of release of mediators, i.e. cytokines, and reduced microvascular leakage, which would mean decreased edema, and inhibition of phospholipase A2 and cyclooxygenase enzyme. You have reduced bronchial reactivity. This is reduced asthma exacerbations, and you do not relax bronchial smooth muscle. So, corticosteroids work on inflammation by inhibition of influx of inflammatory cells after exposure, inhibition of the release of mediators, i.e. cytokines, reduced microvascular leakage, so decreased edema, and inhibition of phospholipase A2 and cyclooxygenase enzyme. And they reduce bronchial reactivity by reducing asthma exacerbations, and they do not relax bronchial smooth muscle. Corticosteroids, you can have inhaled corticosteroids such as beclomethasone and budesonide, fluticasone, flunizolide, and triamcinolone, and this would be a first-line regular therapy. Then there's oral or intravenous corticosteroids such as prednisone, methylprednisolone, and betamethasone and triamcinolone. And this is for severe asthma, so for status asthmaticus. So with mild to moderate asthma, you would use corticosteroids in combination with beta-2 receptor agonists. And with severe asthma, then, which is called status asthmaticus, then you'd use oral or intravenous. Corticosteroids can have adverse effects. So, one such adverse effect is iatrogenic Cushing syndrome. This includes diabetes, hypertension, peptic ulcers, psychosis, and delayed puberty, and inhibition of hypothalamic pituitary axes. So this would be adrenal suppression if sudden stop in treatment, and other side effects such as oral pharyngeal candidiasis, and a gargle and spit after every treatment. Oropharyngeal candidiasis. You can avoid this by gargling and spitting after every treatment. You can also get hoarseness, which is a direct effect on the vocal cords, and delayed puberty. And this would be delayed puberty outside of the iatrogenic Cushing syndrome. So the main things are adrenal suppression if there's a sudden stop in treatment, or iatrogenic Cushing syndrome, oropharyngeal candidiasis, and hoarseness and delayed puberty. The risk can be minimized by, if you're using the inhaled route, 4 puffs of 400 micrograms beclomethasone, 10 to 15 milligrams, or prednisone, being administered in the early morning, which is at the peak of endogenous ACTH, and then a gradual tapering will occur. And if you gargle and spit after every treatment, and if you that would reduce your oropharyngeal candidiasis and reduce hoarseness. And you can use newer drugs such as cyclosinide and a prodrug which is activated in the bronchial epithelium. So to go over that again, iatrogenic Cushing syndrome causes diabetes, hypertension, peptic ulcers, psychosis, and delayed puberty, and inhibition of the hypothalamic pituitary axis causes adrenal suppression if there's a sudden stop in treatment, and other side effects of oropharyngeal candidiasis and gargling and spitting after every treatment. You can get hoarseness, which is a direct effect on the vocal cords, delayed puberty, and the risks are minimized by the inhalation route. So if you have 4 puffs of 400 micrograms per day of beclomethasone, 10 to 15 milligrams of oroprednisone, administered in the early morning at the peak of endogenous ACTH, and then there's a gradual tapering, You can gargle and spit after every treatment, reducing oropharyngeal candidiasis and hoarseness. You can use newer drugs such as cyclizumide and prodrug activated in bronchial epithelium. So, mast cell stabilizers. These include cromolyn sodium and nedocromyl sodium, so they sound crommy and involve sodium. Mast cell stabilizers. NAM, so NAM, NAMcrom, CromNAM, NAMcrom, 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 MANcrom, NAMcrom, 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 CromNAM, NAMcrom, NAMcrom, NAMcrom. Inhibit the release of mast cell mediators. So mast cell stabilizers inhibit the release of mast cell mediators. They're administered by inhalation and they're very poorly absorbed. They have no effect on bronchial smooth muscle, so they're no use in acute bronchospasm. They're only valuable if taken prophylactically. Their main uses are allergic rhinitis and allergic conjunctivitis. So mast cell stabilizers can be used mostly for allergic rhinitis and allergic conjunctivitis. Their examples of mast cell stabilizers are cromolyn sodium and nedocromyl sodium. They inhibit the release of mast cell mediators, and they're administered by inhalation but very poorly absorbed. They have no effect on bronchial smooth muscle, so they're no use in acute bronchospasm. So the mast cell mediators impair the release of AG-AB reaction, and this inhibits the release of mast cell mediators. Newer evidence suggests they have an effect on inflammatory cells and local axon reflexes. They have minor side effects at the site of deposition, such as throat irritation and cough. The serious side effects are rare, but these would be dermatitis, myositis, inflammation of muscles, and gastroenteritis. They're for prophylactic use only, and the use would be diminished since the availability of inhalational steroids. Earlier, they had widespread use in children. The main uses now are for allergic rhinitis and allergic conjunctivitis, so mast cell stabilizers are less relevant these days with the increased use of the inhaled steroids, but they do used to be used quite a lot in children, and there is some evidence that they could be useful, but really they're a bit blah. So, leukotriene pathway inhibitors. Right, so with the leukotriene pathway inhibitors, arachidonic acid goes on to affect 5-lipoxygenase via leukotriene synthesis inhibitors. Arachidonic acid using arachidonic acid goes to leukotriene, but 5-lipoxygenase is an example of a leukotriene synthesis inhibitor, so that stops the arachidonic acid being synthesized into leukotriene. And then leukotriene receptor antagonist stops the leukotriene from causing the receptors to cause bronchospasm. And then arachidonic acid stops cyclooxygenase being converted to something to do with, I don't know, bugger. So leukotriene pathway inhibitors inhibit leukotriene synthesis and They do this by inhibiting 5-lipoxygenase, which is the enzyme of leukotriene synthesis. So Xylutin, which was discontinued because of liver toxicity, was one such inhibitor of 5-lipoxygenase. And you can have inhibitors of leukotriene receptors, which inhibit the binding of leukotriene to the receptor. So these would be things such as montelukast and zafirlukast. So these lukast things inhibit the binding of leukotriene to the receptor. So leukotriene receptor antagonists can be used for allergen-induced asthma and exercise-induced asthma. They reduce the frequency of the exacerbations. They're given orally. They're not effective in acute asthma, and they have minor adverse effects. So these would be headaches, gastritis, and flu-like symptoms. Montelucasts are commonly used. So montelucasts are commonly used, and they're given orally. Allergen-induced asthma and exercise-induced asthma are the things that they're used to treat, and what they do is they reduce the frequency of the exacerbations. They have less efficacy than steroids. They're good for children, but only really used when the children are poorly compliant with their inhalers, so that's their main use. Montelucasts inhibit the cytochrome P450 system, and CS syndrome is a systemic vasculitis accompanied with worsening asthma, pulmonary infiltrates, and eosinophilia. Montelucasts are commonly used. So montelucasts inhibit the cytochrome P450 system, and the cytochrome system syndrome is a systemic vasculitis accompanied with worsening asthma, pulmonary infiltrates, and eosinophilia. Montelucasts are commonly used. So now we're looking at control of bronchial tone. So beta agonists work on adenyl cyclase. They positively stimulate the conversion of ATP to adenyl cyclase. So beta agonists positively stimulate the conversion of ATP to adenyl cyclase, and theophyllenes negatively stimulate the conversion of cyclic AMP, which is formed from the adenyl cyclase, back to AMP because they inhibit phosphodiesterase. So theophyllenes negatively inhibit phosphodiesterase. Theophyllenes negatively inhibit phosphodiesterase, and beta agonists positively inhibit adenyl cyclase. Adenyl cyclase is the enzyme which converts ATP to cyclic AMP. So the adenyl cyclase being positively inhibited means that more ATP is converted to cyclic AMP, and then the cyclic AMP there's even more of this as a result of the fact that theophyllenes negatively inhibiting phosphodiesterase. Phosphodiesterase converts cyclic AMP to AMP, so the phosphodiesterase being inhibited means that more cyclic AMP is left as it is. So cyclic AMP works positively on bronchodilation. So cyclic AMP leads to bronchodilation. So by using the beta agonists to create more cyclic AMP and the theophyllenes to stop cyclic AMP from converted away, then means that there's greater bronchodilation. So that's how these work. Theophyllenes also work by negatively stimulating bronchoconstriction, because the theophyllenes, that's just what they do. There's also muscarinic antagonists, and the muscarinic antagonists are antagonizing the muscarinic constriction. Adenosine and acetylcholine positively they increase bronchoconstriction. So adenosine and acetylcholine, they cause bronchoconstriction themselves. So with sympathomimetic agents, they act via beta-2 adrenoceptors and selective beta-2 agonist agents. And